excited to be able to present to you some data on a study we've done at the Children's Hospital of Philadelphia examining exercise stress testing, in which we found that exercise stress testing on adaptive equipment is both feasible and reliable in Friedreich Ataxia patients. Exercise stress test performance has been proposed as an outcome measure and actually used as an outcome measure for clinical trials in Friedreich Ataxia. And you'll see EST as the abbreviation for exercise stress test performance in this talk. Some people also refer to exercise stress testing as CPET, or cardiopulmonary exercise testing. A change in EST performance could feasibly reflect an intervention's effect on neurologic function, cardiac function, and potentially global functioning in a patient. There is precedent for the use of exercise stress test parameters as an outcome measure in clinical trials for other disease processes. For example, many of the adult beta blocker trials used exercise performance as an outcome measure, and the ongoing congenital heart disease trial in Fontan circulation is also looking at exercise parameters as an outcome measure using an intervention, a drug trial using udenafil. Some of the exercise stress test parameters that we'll be speaking about this morning include VO2 max, which is the maximum consumption of oxygen measured in milliliters per kilogram per minute. This is an effort-dependent measure, which is often used as a surrogate for cardiac output in exercise test performances. We'll also talk about the work rate, which is the watts per kilogram, or the power generated. The maximum work rate can be directly measured on a cycloergometer, which makes use of a cycloergometer particularly attractive. The anaerobic threshold, or AT, is that point at which carbon dioxide production begins to rise out of proportion to the oxygen consumption, and that's due to the switch from aerobic to anaerobic metabolism. So this reaching anaerobic threshold certainly is dependent upon effort, but the measurement of this is effort independent. You don't have to judge whether someone has done a lot or a little bit of work. When you see that someone has made that switch from aerobic to anaerobic metabolism, you have found their anaerobic threshold. So this is often used as a marker of aerobic fitness. Finally, the oxygen pulse, a parameter that I'm particularly interested in the Friedreich population, is oxygen consumption per unit of heart rate. So this can be measured at any work rate, and it's really a surrogate for stroke volume because you're correcting that oxygen consumption based upon the heart rate. So it's useful for assessing changes in myocardial performance over time. So using exercise stress testing in Friedreich ataxia is attractive because it may be a more relevant functional outcome measure than other proposed measures. For example, we love looking at ejection fractions. It's a hard and fast number. You can put your mind around how well is the heart squeezing. But really, a person can feel well at an ejection fraction of 40%, can feel well at an ejection fraction of 65%. And in someone who has a phenotype of a hypertrophied heart, an ejection fraction of 65% doesn't necessarily say a lot about their cardiac prognosis or their cardiac performance. Exercise stress testing may also provide measures of cardiac specific as well as global functional capacity in a disease process like Friedreich's, which has both cardiac and systemic manifestations. Some of the potential pitfalls, however, of exercise testing may be an inability to truly estimate the full functional capacity of someone, even using adaptive equipment that tries to take their particular disabilities into account. You also need to make sure that you have similar effort put forth in every test, a similar testing environment with similar equipment, and also similarly trained personnel to replicate the test well each time. And finally, it may be difficult to distinguish between the global and the organ-specific performance using outcome measures such as exercise performance. So exercise has been described and examined in Friedreich ataxia before. For example, in the pediatric idebenone cohort, so this was ambulatory children with Friedreich ataxia, they reported low peak oxygen consumption and low peak work rates in this population compared to accepted norms. And those parameters did correlate with neurologic severity as well as GAA triplet repeat length, but not with echocardiographic parameters in their population. Similarly, I don't have a slide up here from it, but the mechanist trial also looked at exercise performance and found correlation with, the strongest correlation with IARC's score and not with echocardiographic parameters. In this trial, they did not find a significant effect of their drug, so this one was the idebenone study. So before and after idebenone, the peak oxygen consumption and the peak work rate were similar. More recently, Francesco Sacco's group here in Italy used VO2 max by an arm cycle ergometer, and they did not find significant improvement in Friedreich's patients who took the study drug, which was epoprotein, versus placebo. The trial did not report parameters which would tell us how many of them reached a maximum exercise stress test. For example, they didn't report the percent who reached anaerobic threshold. But I did hear from them subjectively that they felt like the patients were able to exercise to maximal volition. Now, what do we know about exercise stress testing on adaptive equipment? Can we really use adaptive equipment and trust the reliability of such performance? Well, we do know from other studies that recumbent leg cycle ergometry performance is similar to upright leg cycle ergometry performance in healthy adult males, at least. So you're using the same muscle groups almost the same way, so that testing is thought to be relatively comparable. We also know that if you extrapolate to a peak VO2, when you perform a submaximal arm exercise test, that this does correlate with maximum oxygen consumption by standard upright ergometry testing in healthy men and women. Now, whether exercise stress testing on adaptive equipment in Friedreich ataxia patients is feasible, reliable, and also reflective of their underlying disease status still is unknown. So we sought to describe whether this is a useful parameter in Friedreich's. Some of you may recognize this handsome young man here demonstrating the use of our recumbent leg cycle ergometer. One of the things we learned early on is it's really important to be able to get the feet strapped in appropriately. So some of our early patients had trouble keeping their feet on the pedals, even though we're in a recumbent position, so presumably easier to stay on the cycle, the feet kept coming off, and so we had to figure out ways to strap their feet in appropriately. Some would use their own bike shoes and pedals, and then we also had to get pedals with straps a little bit more, I guess, rigorous than just a little Velcro. Here we have a young man who's demonstrating the use of our first arm cycle ergometry unit. We also found through trial and error that keeping the cycle ergometer for the arm on a mobile table, while it did allow the patient to stay in their own wheelchair, it didn't allow for really optimal testing based on actually size limitations. So you can see here that our metabolic equipment starts to run into the arm cycle, and then the patient has to reach a relatively long way to get all the way around the arm cycle. And this young man was actually relatively tall with relatively long arms, so he was able to do the test, but some of our patients couldn't. So we actually invested in a tower. They couldn't sit on their own chair with the tower unless we did eventually figure out how to, I think, disengage this chair. But most of our patients were able to transfer to the chair, which then comes up to the tower here. And because it's suspended and the height can be adjusted, they could more readily perform the arm cycle ergometry test and not run into the equipment. Our study at CHOP was really a feasibility study looking at whether the use of arm and leg cycle ergometry exercise stress testing is feasible in Friedreich's patients. We also specifically wanted to assess the test-retest reliability of both recumbent leg and arm ergometry exercise testing in this population. We also wanted to explore whether there were any direct correlations between exercise performance and neurologic status, cardiac status, and global functioning in Friedreich's. And finally, we aim to start to describe the natural history of arm and recumbent leg cycle ergometry exercise testing performance, at least over the course of a year in Friedreich's patients. So we were able to enroll 23 patients, of whom 100%, or 13 of 13 who were placed in the recumbent leg arm of the testing. I guess arm isn't the best way to refer to this, but the recumbent leg portion, 100% of them were able to complete a maximal recumbent leg cycle ergometry test. 8 out of 10, or 80% of those placed in the arm testing arm, were also able to complete a maximal test. One of these patients was first shunted to the leg cycle ergometry portion and was unable to complete that, and we still had room in our arm cohort, and that patient also could not complete either of those tests. And then one who enrolled in the arm cohort, we had already completed the leg cohort enrollment, couldn't keep cadence because of spasticity. Both of those patients who couldn't complete the maximal arm test had a FAR score in the 80s and a GA triplet repeat length in the 900s. Of those who went on to complete retest reliability testing, there were 5 in the recumbent leg group and 5 in the arm cycle ergometry group. And so far, 17 have come back for their 1-year follow-up testing. So our cohort was a relatively young cohort. The mean age was about 19 years of age. We had a minimum age of 8 because we wanted them to be able to be long and tall enough to get on the equipment and coordinate with the metabolic cart. There were no significant differences in terms of age between the arm and the leg cohort. And there were about 50-50 in terms of male and female. The average GA triplet repeat length was in the mid-700s, and there were 2 patients who had a point mutation, 1 in each group, the arm and the leg. The average age of onset was about 9 years of age in our cohort, so relatively young. Now, we specifically, for this feasibility study, selected patients who were low risk from a cardiac standpoint. So we didn't take anyone who had significant echocardiographic dysfunction. And you can see that reflected here. The average ejection fraction in our cohort was normal at about 65%. And they couldn't have had any history of significant arrhythmias also to participate in this feasibility study. There was a difference between the arm and the leg group with respect to their average FAR score. So the median FAR score in the arm cohort was 63, and the median FAR score in the leg cohort was lower at 57. Actually, it wasn't significantly different, but they tended to be a little bit lower. So how did they do on our various exercise test parameters? Not surprisingly, similar to some of the other studies, the VO2 max was lower than reported norms for healthy folks on traditional exercise testing, and that was expected. So on an arm cycle ergometer, the VO2 max was about 15, and on the recumbent leg about 23. The oxygen pulse was similar between arm and leg cohorts at about 7. Anaerobic threshold was about 14 on the leg cycle ergometers and 10 on the arm, and maximum workload was higher on the leg. You can do more work and generate more power using a recumbent leg cycle ergometer than an arm cycle ergometer. Now, one other thing that we explored with this study was that we used a questionnaire. It's called the PADS-R questionnaire, so physical activity and disability score, and this is a revised scale back in 2007. The scale is, I believe, -3 to +3 with a higher positive number, indicating a higher or less disability score in physical functioning. These are all self-reported parameters that looked at how much exercise or leisure time activity someone is able to perform in their daily life, overall general activities, what therapies they're involved in, whether they're employed and what degree of physical work they do in their employment, and then whether they're in a wheelchair and at what point they have used those aids. The average PADS-R score was significantly higher in our leg ergometry group as compared to our arm ergometry group. So I'm particularly proud of this data looking at test-retest reliability. You'll see here that maximum work and work corrected for weight, so work rate, was quite reliable both in the arm and in the recumbent leg cycle ergometry group. So the interclass coefficients were basically 1 for the work in both groups here, the arm and also the leg. And then also across the board for all the exercise parameters, there was really good interclass coefficients for the recumbent leg cycle ergometry group. I'm quite confident that the leg cycle ergometry in the FA population is quite reliable. So oxygen pulse, VO2 max, anaerobic threshold, and corrected work all had very good interclass coefficients. To To the question of how exercise performance relates to patient characteristics, we found that age and longer GA triplet repeat length does predict a higher oxygen pulse and a lower, age predicted a higher oxygen pulse and longer GA triplet repeat length actually predicted a lower oxygen pulse. We also found that the lower FAR score and a higher PADS-R score predicted VO2 max and work rate. Now, when we use linear regression analysis, we found that age, sex, and GA triplet repeat length all predicted oxygen pulse, but not VO2 max, anaerobic threshold, or maximum corrected workload when corrected for which type of exercise was performed. So to look at that in a little bit more detail, here we're looking at VO2 max, which again is a surrogate for cardiac output. And again, we found that there was no prediction of VO2 max by age, by GA triplet repeat length, nor by male or female sex. Oxygen pulse, however, was predicted both by age and by GA triplet repeat length and by female sex. Anaerobic threshold, which again is a marker of aerobic fitness, was not predicted by any of those parameters. And finally, work rate, or the power generated, likewise was not predicted by age, GA triplet repeat length, nor sex when corrected for the exercise type. Now, I mentioned that we have not yet completed our one-year follow-up data collection, but just to give you a preview, we have so far not seen any significant changes over the course of 1 year by mixed effects linear regression models adjusted for the type of exercise when we look specifically at oxygen consumption, oxygen pulse, anaerobic threshold, maximum workload, and PADS-R total score. We do have more work to be done. Now, I'd really like to look at exercise performance correlations with those subscores on the PADS-R questionnaire. And then many of these subjects do participate in the CCRN study, so I'd love to see if any of their quality of life metrics correlate with their exercise performance. But also, of course, like to complete and describe the one-year natural history of their exercise performance and perhaps beyond if these folks are willing to come back for 2, 3, even 5 or 10 years later and perform another exercise test for us. And I don't know how many of you were able to catch the presentation by Dr. Yan yesterday, but we're certainly very interested in looking at any potential molecular modifiers of exercise performance and really look at whether exercise could be not just an outcome measure, but a therapeutic intervention for patients with Friedreich's. So to conclude, test-retest reliability of exercise performance in FA appears strong along many traditional parameters using adaptive equipment, including recumbent leg ergometry. And specifically, if you look at peak work parameters, it's also reliable using an arm cycle ergometer. Many, but not all, Friedreich's patients can complete an exercise stress test on adaptive equipment with very nicely reproducible results. We also found that age, GAA triplet repeat length, and sex predict oxygen pulse. Ejection fraction did not correlate with any of the exercise performance parameters in this cohort of folks who have relatively normal ejection fraction at baseline. The FARS and PADS-R scores also correlated with VO2 max and work rate. And finally, exercise stress test on adaptive equipment shows promise as a reliable outcome measure for clinical trials. Thank you very much.